People that are coming in slowly, but I'm going to go ahead and get started. I'd like to welcome everyone to the very first webinar that we're hosting at Cellular Peptide, specifically for provider education. My name is Josh Dixon. I'm a registered nurse, clinical researcher, and head of provider education with Cellular Peptide. Now, as you all know, this webinar is going to really dive into some of the next level uses of GLP peptides and some of the things that you can do to create a meaningful GLP program that sets you apart from the sea of providers that are offering these peptides. So a little bit more about me. Throughout my role at Cellular Peptide, I've had the amazing opportunity to not only support my own clients in achieving their goals with GLP programs and various others, but to also be able to teach hundreds of providers across the country the ins and outs of what actually makes a peptide program successful. Now, throughout the years, I have personally created a few peptide protocols that are offered at Cellular Peptide, and I've had the amazing pleasure of helping my clients achieve their goals through the programs that I've created. Now, I work with a lot of different people, a pretty broad demographic. I've seen everything from improving metabolic health, helping injury recovery, body composition, hormonal health, and even aesthetics. So throughout my presentation today, I'll be guiding you in not only fully understanding GLP peptides, but also teaching you what actually makes a successful GLP program so that you can be the experts that your patients desperately need you to be. Now, while this webinar is focused on the use of GLP peptides, that is by all means not where the story ends. I can promise you that a portion of your patients are already seeking out other classes of peptides online for different purposes. So regardless of whether you are ready to support these clients or not, they are looking for these products. And more importantly, they're looking for a professional that can help them achieve their goals with the products. So at the end of the webinar today, I'll cover exactly how you can get everything you need to be an expert on all peptides that we offer and not just GLPs. Now, before we get into the outline and the objectives for our webinar today, I know that some of you guys here are a part of our newsletter, and that's how you found out about this webinar. But not all of you are actually signed up with us as a provider that is able to offer our approved peptide protocols. So for this reason, I wanted to quickly cover the cellular peptide system. What is it? What do we do? And why is it this way? So kind of the secret sauce of what we've developed is a compliant peptide system that protects the licenses and credentials of the providers that work with us. And to our knowledge, even years after doing this, we are the only peptide company that operates in this way. So first and foremost, the whole reason you guys are all here, peptides are taking the world by storm in all aspects of health and wellness. So many providers want to start offering peptides in their clinics, not only to add ancillary income to the practice, but to improve your patients' outcomes when they choose to work with your clinics. So that begs the question, if everyone wants to offer them, why don't they? Well, the number one roadblock that providers face is legal compliance. Most peptides that your clients are looking for are not FDA approved, and therefore there is no mainstream easy way for you to offer them without some type of risk. So here's the thing that most providers don't know. They look at the FDA approval, see that it's not approved, and it's just, oh, that's out the window. It's not possible. But just because a product is not FDA approved, it doesn't make it illegal to use or to sell. All it means is that anyone using the product needs to do so through research. Now, here's where we come in. Instead of being another one of the 1,000 peptide companies out there that sell the individual vials that are labeled not for human consumption, we decided to create something that was different. So Cellular Peptide is a private research organization that uses FDA-approved institutional review boards, or IRBs, to approve our protocols as human research projects. So as a certified or licensed provider, this gives you the ability to submit your credentials to our IRB, become an approved provider, and then as you see clients in your clinics that you think would benefit from peptides, you recommend them over to whatever protocol is best for their goals. So joining our system as an approved provider in this way is what allows our IRB to protect your license and shield you from liability, because you are a licensed provider that is operating within an IRB overseen research organization. You are not prescribing peptides. You are a provider within the research organization. And like I said, anytime that you are seeing a patient or a client of yours and your assessment leads you to believe that they may benefit from one of our peptide protocols or another, you educate them on what it is and how it works. And if they want to participate, they sign our onboarding forms and they get sent everything they need to do the entire program at home. So with all things considered of this landscape and the liabilities and what you can and can't do, this peptide system that we've built is the most above board way to compliantly offer peptides within your clinic through our research programs. All right, now that's out of the way, let's cover the topics of discussion for today's webinar. So to start us off, we're going to be covering the concept of incretins and the various generations of incretin modulating peptides, also known as GLP peptides. I will refer to both of those things synonymously. Incretin modulating peptide, GLP peptide are equivalent. Now, there's been a couple of different generations of these incretins that have come up. We'll talk about kind of what those different iterations have brought on. And then after we talk about each generation and the corresponding mechanisms, we're going to go into our beyond weight loss kind of category, where we'll be discussing some of the newest clinical findings that incretin modulating peptides have brought forth and discuss potential applications of those findings. Next, we will hit the various side effect profiles of each generation of GLP peptide and talk about how to mitigate some of those side effects. And then finally, we will use that information to discuss some of the most common mistakes that providers make when trying to develop their own GLP program. And then using that information of the common mistakes, I'll tell you what I've done to create GLP programs that have consistently delivered the results that my clients were looking for, and how I educate my clients about my program and why it's different. Then finally, at the very end, we'll cover some examples of slightly different types of patients that you may see in your clinics that may benefit from one generation of GLP more than another, just based on their needs and their goals. All right, so let's get into it. The very first thing we need to know about these peptides is the concept of an incretin. Now, in 2009, the American Diabetes Association updated their treatment algorithm for type 2 diabetes to include incretin-based therapies. That was a really big moment because up until that, it had just been about the insulin response and insulin resistance. And now, back in 2009, they came out with this incretin modulating concept. So what actually is an incretin? An incretin is a gut hormone that is released from the gut after we eat. There are two main ones. There is GLP-1 that is secreted by the L cells, and GIP secreted by K cells, just in different parts of the gut. In healthy physiology, these hormones do four things. They amplify insulin release, they suppress glucagon, slow gastric emptying, and signal satiety. Basically, that you're full. Now, here's the thing I really want you to remember. About 2/3 of the insulin response that comes after eating a meal comes from this incretin effect. It's not just insulin, it's not just carbohydrates or glucose hitting the pancreas and releasing insulin. The incretins play 2/3 of that role of coordinating how insulin is released and how the tissues take it up into the tissues. Now, in patients with type 2 diabetes, this incretin effect is blunted. The beta cells of the pancreas become less responsive, and it doesn't happen evenly across both GLP-1 and GIP. So beta cells become less responsive. They completely lose responsiveness to GIP and only partially maintain responsiveness to GLP-1. So this is known as the incretin defect, and it's the physiological gap that incretin-based peptide therapies really close within the diabetes and the metabolic syndrome type of arena. So let's zoom out for a second and talk about that obesity and type 2 diabetes. These two things are so tightly linked that the field has actually now come up with a new term called diabesity. And this is because 80% of type 2 diabetes patients are overweight or obese. That high overlap is due to these two things sharing the same mechanisms. And this can really be seen with the concept of visceral fat. Visceral fat is not just stored energy like subcutaneous fat is. It is a metabolically active tissue that actually pumps out inflammatory cytokines like tumor necrosis factor alpha and IL-6. Those cytokines then interfere with insulin signaling at the cellular level. They reduce glucose transporter expression and drive oxidative stress. So while that's happening, at the same time, obesity lowers adiponectin and drives leptin resistance, giving us miscommunication between gut and brain. And all of this converges on one outcome: increased insulin resistance, and then that is layered on top of beta cell dysfunction from the type 2 diabetes. So if you let this go on for long enough, we develop metabolic syndrome, and that ends up impacting nearly every part of the body: cardiovascular, digestive, our weight, insulin resistance, glucose transport. All of that stuff goes haywire when someone develops metabolic syndrome. So patients with both type 2 diabetes and obesity kind of show all these problems at once. The insulin resistance, reduced GLP-1 sensitivity, and impaired GIP secretion. And that's kind of exactly what these peptides and these therapies were really made to kind of rectify within the body. All right, so now that we understand what incretins are and how these peptides are incretin modulators, let's talk about the peptides themselves and how they have evolved. I think about these in 3 generations, each one building on the last. So our first generation is just simply GLP-1 receptor agonists, or monotherapy, essentially. The first generation, you probably know semaglutide the best out of all of them, but there are several solely GLP-1 receptor agonists. Semaglutide and these other agonists, they really mimic GLP-1 in the body. So when they're taken, they actually drive insulin release, helping manage those blood sugars. They suppress glucagon, which is a way that our body stores energy that we don't want to store as fat, but we don't want to use right now. And then GLP-1 slows gastric emptying. making someone feel fuller for longer. Now, two of these, exenatide and liraglutide, were both used exclusively for accessory management to diabetes, but semaglutide was the first to receive FDA approval for obesity. And it really was significant in clinical trials that led to the approval of semaglutide for obesity. There was weight loss in the range of 15 to 20% of total body weight at therapeutic doses. So this is something that really rivals what bariatric surgery was doing, but of course is a whole lot less invasive. There's better compliance to it. And so these GLP-1 receptor agonists are really the foundation of incretin therapy. And each generation after just builds on top of those mechanisms. The next generation that came to be are going to be the dual agonists, such as tirzepatide. Now, this generation has an equivalent pull on GLP-1 function and GIP function. Now, adding GIP, which is glucagon or glucose insulinotropic polypeptide, amplifies the weight loss effect and further improves insulin sensitivity. GIP is really the receptor that is helping patients have equilibrium in their blood glucose levels. And then we have the GLP-1 on top of that for the appetite control. So in the SURMOUNT-1 trial that happened with tirzepatide, patients saw a mean weight reduction of anywhere from 15% all the way to 20.9%. Going from the 5 milligram, 10 milligram, and 15 milligram doses. Now, everyone loves to talk about how much better tirzepatide is for weight loss specifically than any other incretin modulator. But here's the caveat that I want to put forth. Because tirzepatide is more potent, it can lead to higher weight loss, but it does demand more oversight from the provider. We really have to be on top of clients that are on tirzepatide because this potency is so strong to the point where food noise is non-existent. And when food noise is completely eliminated and people are chronically undereating, then nutrient deficiencies can show up really fast if dietary intake and protein intake isn't managed really well. Now, I've really seen this firsthand. I've worked with clients that were on long-term prescription tirzepatide, like 2+ years, who, yes, they did lose a significant amount of weight, but upon further testing and different diagnostic tools, we found out that a meaningful portion of that weight was muscle mass that they lost and not just fat. Now, that is never a desirable outcome. When someone loses their muscle mass, we can actually end up putting them in a worse metabolic position over time. And we'll go into that a little bit deeper in one of our next objectives after this. But just wanted to give that caveat. Yes, tirzepatide is stronger. Yes, it does have a higher body fat or body weight percentage decrease. But you've got to really be careful that the majority of that is not muscle mass. And then furthermore, with the nutrient deficiencies, I'm sure a lot of people have heard about your clients or people that complaining about hair loss and brittle nails. Those are just two other things that nutrient deficiencies can cause. A lot of people think that it's the peptide that does it. It's not. It's the under eating and the not paying close attention to those nutrients that ends up leading to that hair loss, brittle nails, and muscle loss as well. Now, for the one that everyone has been talking about, our generation 3 is our triple agonist, GLP-1, GIP, and glucagon. And this is called retatrutide. So retatrutide is obviously taking the peptide world by storm because of the problems it really solves relative to the dual agonist therapy that we see with tirzepatide. So let's talk a little bit about those mechanisms. Retatrutide adds the glucagon receptor agonism on top of GLP-1 and GIP. Now, normally, glucagon raises blood sugar. It's one of the tools that our body uses if we don't eat food and blood sugar goes down. We can break down glucagon, release it into the body, and that's kind of like a fuel source for us. So normally that would raise blood sugar. But what's been seen is that when it's in this combination of using all three, it does something different. It actually increases energy expenditure and fat oxidation. So that is to say, when someone is just at a resting state, the basal metabolic rate, or the number of calories that they are burning at a resting state, is actually increased when they're on retatrutide. And one of the really unique things that we've seen is and I can refer to it as Reta or retatrutide, but Reta has been able to kind of create these new metabolic set points. So people that have those low metabolisms that may have been influenced by menopause or just, aging and hormone changes, we've seen an ability to increase that to a new baseline. So their basal metabolic rate increases just from taking retatrutide, and it does persist even past the point that they stop. So that distinction of raising BMR really matters a lot, and especially the specific fat oxidation that Reta does. And this really is different than the other two, because with semaglutide and tirzepatide, we know that those two peptides do what we call indiscriminate weight loss. And that's exactly what it sounds like. The body does not discriminate between both muscle and fat. You will lose both. Now, a lot can be remedied with diet and oversight, but with retatrutide, that really has gone away. We know that retatrutide specifically targets fat metabolism and spares that muscle kind of because that glucagon action as well. Now, Reta is still in its clinical trials, but early data has shown that more than 24% weight loss over 1 year. Now, that is at the highest dosage that is being tested within these trials, which is a very high dose, and I don't recommend that clients ever go up that high, but it is striking to see that those that were compliant with that dose did reach that 24% weight loss. Now, retatrutide is the most metabolically balanced of the three, because it engages these three receptors all evenly at kind of 33% each. It appears to produce a more durable, well-rounded metabolic transformation. Yes, we get the weight loss and it promotes fat burning, but we preserve that muscle mass, and we actually alleviate a lot of the GI-related side effects that were commonly associated with either semaglutide or tirzepatide. Just a more balanced way of it working within the body. So here's how I like to think about each receptor that's been added throughout each peptide generation. Each receptor is its own lever that we can pull within the body. GLP-1 alone is the foundational receptor. It's the starting point, and all three peptides share GLP-1 agonism. It just differs in how much are we pulling that lever down. So using GLP-1 agonism alone will heavily reduce appetite, and it will grind GI motility to a near halt. Things do not move very fast. And that really makes our clients eat less. It makes them be fuller for longer. But pulling one lever 100% of the way can lead to some unfavorable outcomes that we'll cover here soon. Then we have our dual agonists that use two levers, the GLP-1 and the GIP lever. This creates increased potency, bigger weight loss ceiling, and also more room for side effects and lean mass lost if the program isn't managed well. Then finally, our triple agonist retatrutide adds a third lever, being glucagon. This third lever really carries a lot of weight in promoting an actual metabolic transformation rather than just forcing weight loss through undereating. Glucagon agonism increases that basal fat metabolism. It helps combat fatigue and it actively works to preserve that lean muscle mass because the muscle can just feed off the glucagon that's being released. So it's the same foundation for each generation, but as you go forward, they add another lever that we can pull that can increase our precision when working towards certain goals. And that precision is exactly what's going to matter when we talk about side effects and the mistakes that turn a good peptide choice into a bad patient outcome. All right, so objective one, a recap. We have incretins are gut hormones. We have GLP-1 and GIP. 2/3 of the insulin response is from those incretins directly. Type 2 diabetes creates an incretin defect, and incretin modulating peptides can correct that defect. We have 3 generations to choose from. Each has their own lever to pull, and diabesity can be combated with these incretin peptides alongside your client's lifestyle change. All right. So now that we've covered that, we're going to move into the title of our webinar here, Beyond Weight Loss, Expanded Clinical Applications of these GLP peptides. Now, there's going to be some studies that come up here, and we're going to correlate them by body system. So first off, let's start with cardiovascular. Now, a lot of you may have heard about some of these cardiovascular benefits that semaglutide or other GLPs can provide, but I'm going to show you the studies here. So the SELECT trial was published in the New England Journal of Medicine, and it enrolled adults who were overweight or obese with established cardiovascular disease, but without diabetes. And that's really an important part here because diabetes was not a part of what they were studying. These people did not have that issue. It was just obesity with cardiovascular issues. Patients in this trial received semaglutide at 2.4 milligrams weekly, which is the same dose used for weight management, and were followed for major adverse cardiovascular events, heart attack, stroke, and cardiovascular death. The result was that semaglutide reduced these major cardiovascular events, but independently of how much weight the patient lost. So it wasn't as if, oh, if you lose 20 pounds, your cardiovascular events go down by 20%. We were seeing a correlation that GLPs were reducing cardiovascular events even independent of how much weight was actually lost. So this just shows that the GLP semaglutide was actually protecting the heart through some mechanisms beyond weight loss itself. The next study we have, it was on heart failure with preserved ejection fraction. So this specific form of heart failure, HF with preserved ejection fraction, has been historically difficult to treat. So in this study, they took adults that had this condition along with obesity. Again, they took 2.4 milligrams of semaglutide weekly, and researchers tracked a validated heart failure symptom score along with weight and functional status. So this one is a bit hard to track because these functional heart failure symptom scores, these are subjective things that the patient experiences related to their heart failure. But a majority of the participants in that study saw significant improvement in their heart failure symptoms and their physical limitations that heart failure usually brought on, plus weight loss in addition. So in a population where there have been very few effective tools, this has shown promise to being able to alleviate some of those heart failure symptoms. The next system we have some new information on is going to be the renal system. The study that was done on this was called the FLOW trial. They enrolled patients with type 2 diabetes and chronic kidney disease, and this is a population that's at high risk for dialysis and cardiovascular death. They took semaglutide 1 milligram weekly, and that was just added on to the standard of their care. The result was that semaglutide reduced the risk of major kidney outcomes, including kidney failure and the rate of kidney function decline, as well as death from cardiovascular causes. So this one was actually significant enough that the trial was stopped, and it got approval, for this benefit. So this is kind of the citation that you can use when someone talks about GLPs protecting organs. All three of these that we've just brought up are all evidence of GLPs having unique mechanisms that protect internal organs. Next up, we have the liver. In the Essence trial, they specifically looked at MASH, which is metabolic dysfunction associated steatohepatitis. And the Essence trial studied adults with this condition and liver fibrosis. Semaglutide was given at 2.4 milligrams weekly, and the primary endpoint required a liver biopsy at 72 weeks to confirm actual histological improvements or not. So they were not just looking at imaging or blood markers. They actually took a biopsy of the liver 72 weeks after the trial had started. Now, this result is pretty shocking. 62.9% of patients on the semaglutide achieved resolution of steatohepatitis with no worsening of fibrosis, and that was compared to only 30% on placebo. So this evidence was strong enough that semaglutide received FDA approval for MASH in August of 2025. So this is a genuine new application, not an off-label kind of use. People are using it specifically for this. Now, based on that success, they ended up doing another one called the Synergy NASH, a phase 2 trial of tirzepatide in the same patient population, which showed the exact same percentage of benefits, really. About 62% of patients had no worsening of fibrosis. And that reinforces that this benefit isn't just unique to semaglutide. It is in the broader mechanisms of the incretins themselves. All right, this next one is important to present because although there was a lot of hope for this trial, it didn't go exactly the way that many had hoped. There was two that were done. One is the Evoke and one is the Evoke Plus trial. They studied oral semaglutide in adults with early Alzheimer's disease and tracked cognitive and functional decline over time. Now, the result was that semaglutide did not slow clinical progression of Alzheimer's disease. It did improve certain Alzheimer's-related biomarkers, but those biomarkers did not translate into any meaningful clinical benefit. So I wanted to add this because it's a valuable teaching example for all of you. A biomarker moving in the right direction doesn't always correlate with a clinical outcome in your client. So that distinction matters when you're evaluating a new claim about peptides, and there's a lot of claims about peptides out there with how popular they've been getting. Now, our next trial that's kind of in the neurological realm was on Parkinson's disease, and this actually tells a different story than the previous Evoke trial. So this trial was called the Lixie-Park trial, and they studied patients with early Parkinson's disease. These patients received lixisenatide, which is one of the earliest GLP-1 receptor agonists that were developed, and that's why it's called Lixie-Park, lixisenatide in Parkinson's. And these patients were followed over 12 months, and the primary assessment metric was motor disability progression as they went through the trial. So in this study, patients on lixisenatide actually had significantly less progression of motor disability than those that were on the placebo. Now, GI side effects were present and more common in the treatment groups, but this is one of the more compelling neurological signals within GLP literature. All right, on to some different systems here. Next one I want to talk about is addiction, and we can kind of correlate here. We know that GLP peptides have this play within the gut-brain connection and the way that we crave things, we crave food, how satisfied we feel. And so this was a really interesting one to dig into. A phase 2 trial published in 2025 studied semaglutide in adults with alcohol use disorder, and it tracked drinking behavior and craving over the treatment periods. Now, this study established an initial signal that GLP-1 receptor activation could reduce alcohol consumption. And so that's what they were really looking to analyze within this study. Now, this study was a 26-week randomized double placebo-controlled trial, and it enrolled patients who were seeking treatment. So that is an important element as well. But these were treatment-seeking participants with moderate to severe alcohol use disorder and comorbid obesity, and they used semaglutide against a placebo. Now, the result was semaglutide actually produced robust reductions in alcohol use in this population. Now, this is a rapidly evolving area. It's a good example of how this kind of behind weight loss story was developed and kind of the things that we're finding out that these GLP peptides can do aside of weight loss. It does need more study to kind of fine tune a protocol for it. But it's really interesting that this kind of signals a move beyond metabolic disease and into reward seeking and behavior kind of activities within the human mind. Next up, we'll cover reproductive. Now, this one is interesting. Reproductive health is one of the earlier and more exploratory applications of GLPs, but a meta-analysis was done that pooled 4 randomized controlled trials that examined GLP-1 receptor agonists, mainly liraglutide, but also semaglutide and some of the others as well, in women with PCOS. Now, what they looked at was they looked at waist circumference, BMI, lipid markers, and androgen levels, because in PCOS, androgen levels are elevated. The result that was seen was significant reductions in waist circumference, BMI, triglycerides, and total testosterone. There was also insulin resistance improvement that was measured by HOMA-IR, but it didn't reach statistical significance. So while this is a thinner, smaller trial, it's a meta-analysis of a couple different studies that were done. I think it's an interesting extrapolation into what these can do to kind of rectify these metabolic hormonal disorders such as PCOS. Next up is our arthritis. Now, joint health. This result actually surprised a lot of people, and it might not be for the reason that you think. The STEP 9 trial enrolled adults with obesity and knee osteoarthritis with moderate to severe pain. Semaglutide 2.4 milligrams weekly was used, and they tracked both body weight and a validated knee pain score and function score. The result that this study produced was significantly greater reductions in both body weight and osteoarthritis-related knee pain compared to placebo. Now, I know that this may seem obvious. Less weight equals less pressure when walking, and less pressure would equate to less pain. And yes, while that is true, many studies have been performed analyzing weight loss and correlating joint pain to that weight loss. What was interesting about the Step 9 trial results is they produced scores that exceeded what weight loss alone had produced in other studies. So further investigation will have to be done to really know why this happened, but it really showed that there was some added benefit on top of losing the weight that GLPs were doing for this joint pain. It could be inflammatory signaling, things of that nature that also cause pain, but more investigation needs to be done. Next up, we have sleep apnea. This was studied in the Surmount OSA trials, studied adults with obesity and moderate to severe obstructive sleep apnea. This study used tirzepatide, and the primary measure was the apnea-hypopnea index, which is essentially how many breathing disruptions occur per hour of sleep. The result was very, very significant. Tirzepatide produced significant reductions in the apnea-hypopnea index, meaningfully improving sleep disordered breathing in this population. Now, this is one of the cleanest additional applications that we have, that we know these GLPs, aside from the actual weight loss, like night by night, as the GLP is in the system, it by itself reduces incidences of how many breathing disruptions that we have within a single night of sleep. All right. Now, we've talked about a lot of good. Now it's time to talk about some of the side effects that can come from each of these different types of GLP peptides. Now, before we just list them all off one by one, I want to kind of give you guys a framework to organize all of this in your head, because otherwise we just don't remember lists of symptoms to memorize. So think of each receptor that we discussed as a lever, just like I said. GLP-1 is one lever, GIP is another, glucagon is third. Every time we add a lever, being every time we add another activated receptor pathway, we gain therapeutic benefit, but we also introduce a new distinct side effect tied specifically to that receptor. So if you understand why a side effect shows up, being which lever you're pulling that is producing it, you can anticipate it, you can explain it to your patients beforehand, and you can manage it proactively instead of reactively. So first off, let's start with the shared layer up here at the top. Because all three of these peptides activate the GLP-1 receptor, just at different intensities, all three carry the same foundational side effect profile. And this is the baseline you'll see regardless of which peptide sits in front of you. The things that they all share are GI dominant effects across the board. Nausea is the single most common complaint across all three. It is heaviest during dose escalation. Then you have vomiting that sometimes accompanies that. You have indigestion, bloating, gas, constipation, diarrhea, and this sometimes will alternate in the same patient from diarrhea to constipation. We have esophageal reflux, we have headache, we have hypoglycemia. That's predominantly only seen when someone takes some kind of adjuvant diabetic medication, be that metformin or any of the other blood glucose regulators that are out there. We have abdominal discomfort, something very specific called the sulfur burp, and then decreased appetite. We know that this is the intended effect, is to decrease appetite, but sometimes it can go into that problematic range where undereating and those nutrient deficiencies can occur. Now, let's go kind of more into some of the rare ones that all three of them can produce. Now, again, these are rare, but it is something that can happen throughout all three, being acute pancreatitis, gallbladder disease, and cholelithiasis, and then acute kidney injury. Now, the kidney injury is almost always secondary to dehydration, and it's not a direct effect that the peptide has on the kidneys. And then, like I said, that hypoglycemia is really only there with adjuvant diabetes therapies as well. One of the really unique ones that is now being considered in surgical procedures is they are now asking about if you use GLP-1s or not, because when you are, your gastric emptying is slowed, and that is a big risk for aspiration during your surgery. So really important if you're working with people that are anticipating surgeries or what have you, tell them to be very upfront with the surgeon that this is what they're on. Now, finally, in that column up at the top, we do have a black box warning. Now, a lot of you have probably heard about this before. It's the thyroid C-cell tumors. This is on the box of semaglutide, of Ozempic. Now, what's really interesting about this is this entire mechanism was only seen in rodent studies. They saw in rodent studies that thyroid C-cell tumors could be increased by GLP-1 use. So on the box, they contraindicate it for anyone with a personal or family history of medullary thyroid carcinoma or MEN2. Important clarification, those types of thyroid cancers are very rare in the first place. Those two types only represent about 3 to 4% of all thyroid cancers that are out there. So it's not something you'll encounter a lot. And again, the entire warning came just from a rodent study. All right, so with GLP-1 receptor agonist alone, we are not using any additional levers. We have those GI side effects that we covered at the top. With long-term GLP-1 use, we have seen a couple of cases of gastric paresis just because of that slowed gastric emptying. And then one other thing that's unique to just a GLP-1 receptor agonist is dizziness and sleep disturbances. Not so much insomnia, but not sleeping fully through the night, and then dizziness upon position changes as well. Now, a note on semaglutide, it does have the longest real-world track record of the 3 peptides we're talking about today. It's been used in treatment since 2021, so we do have a more full kind of picture of even some of the rare side effects that it can cause. But generally, GLP-1 receptor agonists, they're kind of limited to those GI upset side effects, and then we have got the dizziness and the sleep disturbances on top. So now that we've covered that section there, we'll go into the dual agonists. So when we add that second lever, GIP, there is something that may surprise you here. Adding that second receptor doesn't necessarily mean you add more side effects. In tirzepatide's case, it's been seen that co-activating GIP does actually appear to offset some of the GLP-1 driven nausea and vomiting that people experience. I have talked to so many people who had bad GI side effects on semaglutide. They switched over to tirzepatide and they were over the rainbow about no more nausea, but then they were getting introduced to a whole different host of things going on. So one of the reasons that they think that whole decrease of nausea happens is that GIP agonism blocks something in the gut related to nausea and vomiting specifically, while still preserving that appetite regulation. Now, with specifically 2 dual agonists like tirzepatide, we have 2 pretty common things. We have the insomnia and body aches. So again, different from the sleep disturbances that we see with semaglutide. This is true, like more true insomnia where people just don't feel tired. And then we've got the body aches. That could be a whole host of things. It could be under eating. It could be the peptide itself, just giving that really achy feeling. Now, a lot of participants or clients that are on this, they will kind of evolve past having those body aches, but for some people, they don't go away. And then the real big ones, hair thinning and muscle loss, are the most pronounced side effects with tirzepatide. Again, a lot of this can be remedied with whole food diet, supplementation, careful oversight, really making sure that our body still has all the vital nutrients that it needs, but still with that caloric deficit. But it does take a lot of work. It does take a lot of check-ins, making sure that your client is still on that good path where we are staying full of nutrients and eating appropriately. All right. Now, finally, for Retatrutide, we have that third lever of glucagon. This is where the side effect signature does become genuinely distinct. There are a few brand new things that we have seen with Retatrutide that do not happen on the other two. The most pronounced and the most noticeable one is called dysesthesia. This is a standout finding here. Dysesthesia is abnormal skin sensations described as tingling, burning, pricking, or numbness. I've also heard of it called a minor sunburn feeling across the body, but with no sun exposure. So it didn't really correlate to that client of why that was happening. Now, like I said, this is not seen with the other two. So suspicion is that this dysesthesia is something specifically tied to the glucagon receptor as the driver. This could be possibly through effects on peripheral nerve signaling or even thermogenesis, how people maintain their own internal temperature. I always kind of know when a client is experiencing this because they tell me, man, I go from my bedroom that's all cold out into the living room that's hot, and I immediately start sweating. And then I go back into my bedroom and I get goosebumps all over my body. That is that big fluctuation in thermogenesis, and that kind of gives me that light bulb that this person may be having this side effect. Now, in the clinical trials that have been done with tirzepatide, about 1 in 5 patients on the highest dose of that trial had dysesthesia. So about 20% of participants had it, but the highest dose in that study was extremely high. I believe it was 16 milligrams of retatrutide per week, which is much, much higher than people need to go for those therapeutic benefits. So just by managing that lower dose, taking it slow, titrating up slow, we've been able to avoid a lot of discomfort from this dysesthesia. The second thing that's unique to retatrutide is actually fatigue. Now, this again comes back to that glucagon receptor agonism. So when we agonize that receptor, we're increasing that basal metabolic rate. So if you have that in mind, and then you have this caloric deficit going on at the same time, the body is going to feel like the engine is burning really hot and my fuel sources aren't getting replenished. So that's kind of what brings up the fatigue. People just feeling weak. It usually is limited to the first 3 or 4 doses as their body is acclimating and they're slowly going up in that dose. It usually evens out after their body has adapted, but can also be benefited by just making sure they get some very nutritious food in them that their body can use for that fuel. Now, when you consider these side effect profiles, it shouldn't be anything that limits your decision of which one to use or which not. They are just things that we can help support our client in avoiding. So if we want to really avoid muscle loss, we can use retatrutide. The glucagon goes to preserve that muscle mass, target fat decrease, but say they get the dysesthesia side effect. Well, there's a couple things that we can do, decreasing dose, going back down in dose so their body has more time to acclimate, or even supplementing zinc has really helped this situation in a number of clients that I've taken care of as well. So long story short, there's always kind of a way. There's some things that you can do with lifestyle and with supplementation that can really go to avoid a lot of these things. All right. So now that we've gone over the main side effect profiles for each generation of these GLP or incretin modulating peptides, let's get into some of the common mistakes that providers unfortunately make when creating a GLP program for their patients. If you have extensive experience using GLP peptides with your clients, you may have seen some of these issues before when you might take on a client that was on a prescription version of these peptides from their primary care or from other sorts of physicians that may prescribe them. Once we have covered what the core mistakes are, I'll provide some actionable steps that you can take to make sure you're avoiding these issues when creating your own program. So let's get into them. All right, mistake number one and the most glaring. GLP peptides are not a magic bullet. They do require lifestyle changes for metabolic transformation to occur and be long lasting. Now, mistake number one, you don't need to change anything about your lifestyle. This may seem obvious to you guys, but it really was shocking how many clients I've worked with that got on a prescription GLP, was approved by their insurance because they were diabetic, they were obese, they had all the hallmarks that, made them a candidate. And they were on them for 2 or 3 years. And when I do my assessment, I talk about how those 2 or 3 years went. And I ask, like, what kind of guidance were you given when you were given this prescription? It is a shocking number of them that just said, my doctor said I qualified for this medication and told me that all I need to do is take my weekly shot and weight will be lost. Now, this is never going to be an approach that creates long-term success. It's only an approach to make someone a lifelong patient on a prescription medication. I'm a firm believer that with the right GLP program, a client can participate in it, achieve their health goals, taper off the peptide, and then maintain their success with a healthy lifestyle, completely avoiding that rebound weight gain. Now, sometimes it does take a lot of education with your patients to explain why that is the case and why their compliance is important, but it is a core tenet of these programs. We do need to complement with lifestyle changes. All right. Our next mistake is thinking that a higher dose is always going to equate to faster weight loss or more pronounced metabolic effects. This mistake is unique as it often comes from the client or the patient's side. They have good success the first few weeks, then they feel like the weight loss stops, the cravings come back, and food is always on their mind. This is when they'll come to you and they will ask if they should increase their dose. I always find it valuable to remind them that there is such a thing as healthy weight loss, just like there is unhealthy weight loss. Instead of just obliging and recommending that they increase their dose, I take this as an opportunity to assess how the last week of their life went. Did you travel? Did you stick to your whole food diet plan? Did you go to a party where there were unhealthy foods or alcohols? Did you skip any workouts? Did you have increased stress that's abnormal for you? And more often than not, there is something in their routine that was out of the ordinary that we can attribute the decrease in effectiveness to. So remind them that this is a marathon, not a sprint, and support them into getting back into their healthy habits. The majority of the time that I do this, they report further benefits the next week. Nearly every time I have recommended a dosage increase, they come back to me the next week complaining of increased side effects. This shows that the body doesn't need more. It just needs the client to make the right dietary decisions and keep engaging in physical activity. I'm going to take one moment. I need to plug my computer in. Right. Sorry about that. On to mistake 3 and 4. All right. Now, for this one, mistake number 3, this is actually a mistake that clients often make themselves when on a GLP. And this is only paying attention to the number on the scale. Now, why is this an issue? If the intention is to lose weight, why shouldn't we be looking at how much we weigh? The answer really comes down to the various factors that impact the ultimate weight on the scale, what number is showing up. On a daily and even intra-daily basis, our weight will fluctuate from water and food intake, bowel movement routine, water retention, and visceral versus subcutaneous fat. Those all play a part in the number that the scale reads out. So clients being overly focused on the number on the scale can make them lose sight of other powerful benefits that they are receiving while on their program. One notable example that I want to hit is the visceral versus subcutaneous fat. Now, these are two very different things. And while 1 pound of visceral fat weighs the same as 1 pound of subcutaneous fat, the impacts of losing 1 pound of visceral fat is incredibly more significant than losing 1 pound of subcutaneous fat. Remember, I said visceral fat is an active living tissue that surrounds your internal organs. Visceral fat is so metabolically active that it can basically be thought of as its own endocrine organ. Visceral fat will release inflammatory cytokines, leading to constant low-level inflammation, and will contribute to exacerbating insulin resistance. So what I'm basically getting at here is that losing a pound of visceral fat is a huge accomplishment that creates so many lasting metabolic benefits. So it's important to remind your patient or your client kind of what is going on within their body when they tell you, oh, my results stopped, or oh, this week I didn't lose any weight. Keep them consistent, remind them what's going on. And if you have the ability, we can do some measurements. Now, how do we measure visceral fat? Unfortunately, it's not so simple. The only true way is to get a baseline DEXA scan that tells you exactly body composition before they started, and then repeating one of those DEXA scans either in the middle or post program. Now, I know that not every provider has the ability to offer these scans, but if there is some way, a partner clinic, another provider you know that has one, I do highly recommend that you try to integrate that service into the GLP program that you offer. It creates more value and it gives more buy-in for your patients that they're actually going to see their body composition change from before and after their program. For mistake number 4, we have no attention to micronutrient intake. This mistake often ties into the common complaints that providers hear from their GLP clients about plateauing. Now, a lot of you have probably heard that, oh, I was on semaglutide and then I plateaued, and then I went to tirzepatide and then I plateaued, and now I'm on Reta and now I plateaued. Well, there's not always going to be a new generation. They don't just keep getting more effective forever. So let's really talk about what's going on here. We introduced a peptide to the body that modulates incretin hormones within the gut. This then impacts the entire gut-brain axis, allows our clients to have better appetite regulation, decrease caloric intake, and lose weight. So why would this suddenly stop working? Well, just like every other process in the body, every physiological action is driven by a certain set of enzymes, cofactors, or micronutrients. The signal is the peptide. So the peptide is sending the signal to the brain. But if there are none of the required resources around, can we do anything with that signal? You can tell someone to work all day long. If they don't have the tools to work, nothing's going to get done. So this is exactly what happens when people plateau on their GLPs. We burn the body out of all of its fuel sources during GLP use, clients will chronically undereat. we're still sending the signal to the body, but now the body doesn't have the micronutrients needed to efficiently metabolize fat tissue. And now, while this could be an entire webinar just on its own about the necessary micronutrients for peptides, I just want to cover two very important nutrients that are an essential part of specifically getting mitochondria to burn fat as a fuel source. Those two things are L-carnitine and riboflavin, or vitamin B2. L-carnitine is an amino acid derivative, but it functions honestly quite like a vitamin. It's required for what we call the carnitine shuttle that ends up transporting long-chain fatty acids across the mitochondrial membrane. So this is the single biggest bottleneck for fat oxidation. Without adequate carnitine, fatty acids can't get into the matrix to be burned. So we're sending the signal to use fat as a fuel source, but without the carnitine in there, it doesn't have the tool that it needs to actually do that action. And then for riboflavin, it is needed to synthesize the carnitine shuttle enzymes and acts as a cofactor in the actual beta oxidation cycle itself. So riboflavin and L-carnitine go hand in hand. Both of them are necessary. So kind of obvious. If we run out our body of all of our stores of L-carnitine or riboflavin, then fat oxidation will dramatically slow down, if not stop altogether. So this simple issue is responsible for the inevitable comments you're going to get about my GLP stopped working that you'll get from your clients if you don't support the necessary micronutrients. All right, for our final two mistakes, mistake number 5, a calorie is a calorie. This mistake piggybacks off mistake 4 about micronutrients, but it's more targeted at food ingredients rather than just supplementation. Providers who don't have an emphasis in nutrition sometimes will make this mistake. We've all heard about the risks of undereating, and those less versed in nutrition may just focus on adequate caloric intake. That way of thinking does pertain to weight loss in general. Calories in need to be lower than calories out in order to lose weight. But when it comes to GLP use, we already know that caloric intake is going to be lower than caloric burn due to the nature of the mechanisms of the peptides. So what should we focus on instead? The thing that I always tell my clients that are on GLP peptides is this: the peptide is a tool. This tool will help you regulate your appetite and eat less calories than you burn. But eating empty garbage calories of processed food isn't going to do you any good when it comes to retaining muscle mass and preventing nutrient deficiencies. So that's why any client I work with has a whole food meal plan. I am more focused on the quality of ingredients or the quality of the calories being eaten rather than the number of calories just on their own. Whole foods are obviously going to be the most nutrient-dense ingredients that you can cook with. So if you're compliant with the whole food diet, supplementation may just be minimal. If you're not compliant with the whole food diet, you're going to need a whole lot more supplementation than those that are. Furthermore, I require that my GLP clients eat a minimum of 1.2 grams of protein per kilogram of body weight. This is usually higher than others recommend, but it is so important to retain that muscle mass. Because even if your client loses 50 pounds on your program, if half of that was muscle, you just helped them create a less favorable metabolism than they had before they lost 50 pounds. Right. For our final mistake, mistake number 6, cardio over weightlifting. Now, this is not always a provider that promotes this idea. This is again back to the client themselves and the things that they see online and kind of the perception that they have about weight loss and exercise in the first place. is they kind of have this thought that cardio is more effective for fat burning than weightlifting. Now, when I first see a client that's interested in using a GLP for weight loss or metabolic benefits, part of my initial assessment is to talk about their exercise habits, their dietary routine, just their lifestyle in general. And I always focus on what is your preferred exercise method. More often than not, these clients, again, seem to think that cardio is the best option for weight loss. And while I understand where they're coming from, I use this as an opportunity for education. Most everyone knows someone that took a GLP, lost a bunch of weight, but now looks what we call skinny fat. Sunken appearance, loose skin, no muscle definition. You know the image. Getting to this point on a GLP is actually a detriment to metabolic and hormonal health, the complete opposite result than we want to see. When you're correlating this skinny fat image to your clients and then using that as an opportunity to explain that lifting weights is the key to avoiding them seeing that result for themselves. Tie it into someone they know that had that less than favorable result and tell them why weightlifting is your way out of having that result yourself. Weightlifting will not only build muscle, but it actually does accelerate fat metabolism as the body shifts towards that more anabolic state. If you're lifting weights, the muscles need to recover. The body's going to get that energy from somewhere, and it's going to burn down the fat so that your system has energy to keep going. All right. Now that we've covered the most common mistakes that the majority of providers make with their GLP program, let's cover some actionable steps that you can integrate into your GLP program to avoid them. The most profound action that you are going to take is, of course, just education. Education for a GLP program begins before your client ever even takes their first dose. It begins in your initial consultation where GLPs come up as a topic. Education is going to factor into every single point that we're going to cover for what makes a successful GLP program. You can never over-educate a client who is engaged and wants to have the best outcome. So many clients are on social media, they're seeing advertisements on a daily basis for one GLP or another. And as marketing goes, it's almost always all positives and does not set any expectation for what the client needs to know about their GLP use. This is where you can immediately set the stage for how your program is different through your education. During your initial assessment, you should be gathering information about where the client is at right now and what their ideal goals are that they want to achieve through your program. It's during this discovery process that you can sometimes take some time to educate your client on exactly how your program works and can help them achieve that goal while also tempering their expectations. I always like to begin with asking them what background they even have with GLPs in the first place. Have you taken one before and had a good result, had a bad result? Have you just been seeing advertisements but never felt like you were confident enough to pull the trigger? Did you see someone else have success with GLP peptides? I want to know exactly how this came into their mind because that often accompanies certain expectations and fears. Now, based on what you hear, you can kind of latch on to where their basis is and you can educate them along the way. So education is paramount to make sure that your client understands not only how their GLP that they're going to get works, but then you can also go into how and why your program is different from the rest, building trust that you are the right provider to go with. The next hallmark of a successful and meaningful GLP program is dosing based on individual sensitivity. This is the one that a lot of providers get wrong. They know of the different tiers of dosages that prescription Ozempic and Zepbound come in, and they just hop right to one of those. Well, GLP peptides are unique in the fact that every person has their own individual sensitivity to this specific class of peptides. For this reason, week by week dosing on GLPs should be a low and slow titration upwards. These peptides can have a steep dosing response curve. You may have someone that takes their first 2 doses with no changes at all. The 3rd dose produces some weight loss, and then when they move to the 4th dose, a host of side effects come through. This goes back to one of the mistakes we covered. A higher dose does not equal faster weight loss. Sometimes all it does is increase negative effects. So the way that I explain this to my clients is by telling them that my program begins with a low trial dose to assess their personal sensitivity. I tell them that the first dose is really just to see how their body tolerates the peptide, and that we do not expect significant effects, if any, from this dosage. Then, from that point, we move up slowly week by week. If any effects are present, such as nausea, indigestion, constipation, or feeling like they need to force feed themselves, then we've gone too far and we need to step things back until those side effects resolve. This process of explaining how the doses work in my program leads me right into my next point for success. And I call it finding individual sweet spot doses. As a provider, I'm a huge proponent of finding the lowest possible therapeutic dosage for each of my clients on GLPs. The way that I explain this to them is that we want to find their personal sweet spot dosage. And I then go on to explain to them that hitting the sweet spot means that we found a dose that produces 3 main effects: noticeably reduced appetite without the feeling of forcing down food, staying comfortably full between meals and having no desire or cravings for snack foods, and finally, losing weight in a balanced manner. That last hallmark is going to be unique to each person as well, based on their starting weight and their ultimate weight goal. As a rule of thumb, GLP clients should be losing 1 to 3 pounds per week at their sweet spot dose, and this range is considered healthy weight loss. Anything more than that is too fast for the body to be dropping weight and puts them at higher risk for rebound weight gain once they're finished. To continue on, my next 3 recommendations for building a meaningful GLP program all revolve around lifestyle modifications. Everyone you work with is going to be in a different position when it comes to their current health and wellness routine. As the provider, you need to be ready to assess these lifestyle factors and provide guidance to your client for what they need to change and why it is so important to change those things while on a GLP peptide. The biggest lifestyle factors that I promote to my clients revolve around choosing certain food groups or outlining certain food groups that they should absolutely avoid. Those being no fried foods, no heavily processed carbs or refined sugars, no soft drinks, and limiting alcohol intake, preferably avoiding alcohol altogether. Now, I know that that's a lot, and they're probably going to scoff at you for that, but with a good whole food meal plan, that can be a more than satisfactory diet, and sticking to it is going to pay dividends. If this piece of advice is the only thing that they listen to, then they'll be better off than 80% of GLP peptide users. These food groups create inflammation, they're devoid of nutrients, and they are all so easily stored as fat. After that point, I'll go into what types of foods they should be eating and what their supplementation regimen will be on my program. Now, I have talked about this briefly already, but the core focus of their dietary decision-making should be, is what I am about to eat made up of only whole food ingredients? If so, great, you're good to eat it. But the moment you start seeing ingredients that don't even sound like foods, an alarm bell should go off. I'm talking about things like crazy artificial sweeteners, the food dyes, the preservatives, the binders, the fillers. And depending on their starting point, some clients may need more education on how to read a food label than others. Now, for supplements, I do personally include supplements, a select few with each of the programs that I offer to my GLP clients. Now, I've seen this both increase compliance and accelerate results. Many of you may already use them, but my preferred supplements are from Optimal Health Systems or OHS.
Hi guys, sorry about that. Josh, I've just been on the back end listening. Isn't Josh so amazing? My name's Ashley, for those of you who don't know me. I am the owner of Cellular Peptide. Josh texted me and said that his laptop died. So he is frozen. And I think he's going to be hopping back on to finish up. I know we're getting close to the end. Um, and I do not have access to his slides, so I cannot continue for him. I do believe he was talking about whole food supplementation through Optimal Health Systems. Um, he mentioned the carnitine. Oh, here he is. Okay, I'll just let him take back over. Thanks for your patience. I'm sure he'll be back with us in just 1 second.
Yes, I am back. I'm going to start sharing my screen in just a sec. All right, back to where I was. Sorry about that, guys. My laptop charger was not strong enough to be charging my laptop while I did all of this. But we will pick up right where we left off with the OHS supplements. So, like I was saying, every single one of my clients receives two things with their GLP programs. They receive enough Digestamine to last throughout their entire program. And then something new that has actually just launched from OHS, and I've been including with my Retatrutide programs, is called the RPM Pack, which stands for Retatrutide Performance Matrix. We'll cover the actual ingredients and kind of what that does in just a few moments after this slide. To finish off, one of the hallmarks that is going to actually make a meaningful program for your clients is going to be the weight training exercises need to be a part of a meaningful and long-lasting GLP program. We touched on it a bit already, but working on strength training and muscle development is not only going to preserve lean muscle mass throughout their weight loss journey, but it's going to accelerate the metabolism of fat along the way. Some clients are going to be averse to this, and I've experienced this myself. But again, education and support goes a long way. When someone knows why you want them to do something and they know what that thing that you want them to do is going to prevent for them, then that buy-in and that compliance becomes just a little bit easier. Now, there are numerous different workout plans that you could create or use that will satisfy this objective, but there's really no need to complicate things for the client, especially if they're already kind of showing being averse to this type of an exercise. We don't need to complicate it. For those types of clients, my motto is get in the gym and lift something heavy for at least 30 minutes a day. If that's a cable machine, great. If that's free weights or dumbbells, great. If it's calisthenics, such as push-ups, well, that's also great as well. The main point, get in the gym, lift something heavy, work those muscles out, and you will accelerate your progress through your GLP program. All right, so now for the supplements that I personally use with my programs. First up is going to be the Digestamine. A lot of you probably are familiar with this already. It's like the hallmark product of OHS. But this I have been adding from the very start. Just reading the list of GI side effects that GLP-1s can create, this product immediately came into my mind. So I would say this is the single most impactful thing for how the client actually feels throughout the day while being on their GLP-1. And basically what this supplement is it's taken with each meal, and it contains digestive enzymes that are derived from whole food sources. So if you recall, GLPs are going to slow gastric motility, specifically the GLP-1 receptor agonist. This is good for craving control, but it's not the best for digestion. So taking Digestamine with each meal throughout a GLP program will allow the food that your client is eating to be fully broken down for efficient nutrient absorption, but will also keep all food moving smoothly through the GI tract, avoiding indigestion, heartburn, nausea, constipation, things of that nature. Next up is the newer RPM pack. Now, RPM is a Retatrutide performance mix. This product is actually a combination of a custom supplement pack. That's what that box on the right is. And it's combined with L-carnitine. So the design behind this pairing was really all about the micronutrient delivery and delivering all of those that the body needs for efficient fat breakdown. So they take their custom packs that are in the RPM packs, and then alongside it, they have that bag of L-carnitine that they'll supplement with. And again, it's just going to be able to give the mitochondria everything that they need to be able to use fat as a fuel source for energy production. There we go. So it comes with that bag, and then comes with the 60 custom health packs there as well. I'll say it again, these really are an intrinsic part of my GLP programs. I think it increases compliance, it accelerates results, it is a holistic approach. You know, we don't just rely on the peptide to do everything. We use the peptide as a signaling tool. We use the supplements to support the nutrition that the body needs in order to use that signal. And then we support those lifestyle changes so that they can actually maintain their results for long term. All right, our final section here is about client selection. Now, there's tons of different demographics that you'll see with different comorbidities, ages, sexes, you know, everything is kind of different under the sun with who you are going to encounter. So these are going to be kind of basic patient avatars, I call them, and there will be slightly different things about them that may make your mind go towards one type of GLP over another or one generation over another? All right, so first patient avatar we hear. This man, his name is David. So David is a 37-year-old executive at a Fortune 500 company. His work is high stress, mostly sedentary, and like many professionals, his diet follows the standard American pattern, heavy on refined carbohydrates, processed foods, and takeout meals. The unique thing about David is he doesn't feel like cravings are his biggest issue. After he eats, he's full, but it's incredibly difficult for him to cut out his standard American diet. David's issue is more about how easy it is to give into that diet. He's tried doing exercise plans, and even when he's consistent, he felt like he didn't make any progress with the weight loss. Ideally, David would like to drop 40 pounds that he's gained over the past 3 years of working in his office. Over the past few years in this office, he's noticed increasing fatigue, brain fog, and weight gain around the midsection. He's sleeping poorly and recently learned that he has mild sleep apnea as well. When David visited his primary care, his lab results told a familiar story of metabolic syndrome. Elevated fasting glucose, high triglycerides, low HDL, rising blood pressure, and early insulin resistance. And his provider tells him that he's pre-diabetic. Now, chances are you've seen a bunch of Davids in your clinic. This scenario isn't really all that rare. 1 in 3 Americans meet this same criteria for metabolic dysfunction. So, with all of that information in mind, 40 pounds of weight loss goal, metabolic labs out of range, no significant cravings, trouble seeing results from exercise, where does your brain go? My brain goes right to Retatrutide. And I'll tell you why. In my view, Retatrutide is the best GLP for these larger kind of, moderate weight loss goals. It's not 5 or 10 pounds. He's looking to lose 40. So whenever someone's in that kind of 30 to 50 pound weight loss range, Retatrutide has shown the ability to deliver that level of weight loss. And furthermore, for the correction of those metabolic markers, such as his insulin resistance, fasting blood sugar, and triglyceride levels, we know that Retatrutide has the more diverse metabolic mechanisms that can kind of tackle that all at once. So, knowing this information about David, I would begin the education process during our initial consult and lead him into how my program would work for him specifically. You want to tie in the things that you've heard from them, the goals that they have, relate that back to your program and why you can achieve that, with them, alongside them, essentially. Now let's look at a little bit of a different patient. This is Dana. She's 52 years old. She's perimenopausal and she works a sedentary desk job. She's married. She has 2 kids that are grown and out of the house. And when we sit down with Dana and ask her about her goals, she tells you that she wants to lose about 20 pounds. Not a dramatic transformation. She's not chasing that 24% body weight loss. She just wants to feel a little more like herself, kind of get back to that way that she was when she was a little bit younger. Now, here's where Dana's situation gets a little bit interesting. When you dig into her eating behavior, she describes something that you've heard quite a few times before. She calls it her food noise. She says she has constant intrusive thoughts about eating. She grazes in the evenings, always picking up a new snack. She stress eats and she's tired, and she's tried diet after diet. And it's not that she doesn't know what to eat. She knows exactly what to eat. She just can't out willpower the craving. And then there's one more piece about her history that is easy to overlook if you're not asking the right questions. She tells you she's drinking 4 to 6 glasses of wine a week. Not diagnosable alcohol use disorder, but when you ask her why, she just says, I use it to unwind. That right there is a reward pathway pattern thinking and not like a social habit. It's not around other people, it's not at the event, it's personal time unwinding, and it's a reward pathway in her brain. And that kind of highlights how those reward pathways work in her brain specifically. So based on that, ask yourself, is Dana a retatrutide patient or a semaglutide patient? Here is how I would walk through that decision. So first, her weight loss goal. Retatrutide's triple agonist mechanisms give us a much higher weight loss ceiling. That's exactly what you want for a patient chasing a large percentage of total body weight loss. But Dana doesn't need that. She needs a moderate, sustainable result. And semaglutide can get her there without adding the steeper titration curve and side effect burden that comes with that glucagon receptor agonism. Secondly, her craving profile. This is really the heart of it. Deborah's biggest barrier isn't metabolic, it is actually behavioral. It's reward driven, and semaglutide has the most robust data that we have right now on central reward modulation. That's the food noise quieting down that patients describe. Third, with the alcohol, this is where it comes kind of full circle in semaglutide's favor. Semaglutide has the emerging evidence for reducing alcohol cravings and consumptions tied to that same reward center mechanism. For someone like Dana, that's really not a side benefit. It's directly on target with what's driving her relationship to food in the first place. So when you line it all up, she has a moderate weight loss goal. She has a high reward driven craving profile and a comorbid pattern of reward driven alcohol use. So for someone like Dana, semaglutide really is the more favorable choice. Let's use it short term. Let's get her back to her baseline. And let's, throughout that program, she could also do work in therapy. She could also do behavioral types of therapy that, kind of analyze, why do I have this craving? Why do I have this reward seeking behavior? While the peptide is working in her body to make those cravings less frequent. All right. That about concludes our webinar on the kind of